All right, I am live. I'm a couple minutes late and I do apologize. All right, here we go. Going live on Instagram. Ta-da. Okay, got everything where it needs to be. All right, and get my chat box ready. All right, guys. Whew. Here I am. All right, I'm a couple minutes late this evening, just setting up some new things. So I am now streaming to Instagram. So I'm gonna give you guys a couple minutes to jump on board. I'm gonna get my tea ready, get my peppermint tea ready. All right, guys, I see a few of you jumping on board. Hey there, Benny, watching me from the YouTube channel, guys. Using some new audio equipment, still learning some of it. So give me a thumbs up if you can hear me okay. And as you come on board, guys, let me know who you are, where you're from, and what's in your mug this evening. All right, we got some fun stuff planned for tonight. Getting my stuff set up over here. All right, see some more of you jumping on board. Let's see. I'm going to be popping back and forth between my Instagram channel. I know there's a lot of people watching me from the Instagram channel, and this is something kind of new. So I'm really excited. So those of you who've never really seen me before on Instagram, hi, stick around. We've got a lot of great things. We've got Elizabeth coming in from New Jersey. Thank you for joining in. Oh, this is so cool. This is so cool. All right, guys, I'll be introducing myself formally in just a minute or two. I'm going to let some of you guys jump on board. Hey there, Jody in chilly Las Vegas. Oh, I'm so glad to see you, Jody. And we got OPAF joining in online. We got a lot of great people joining in. So I am so excited to be able to finally broadcast to Instagram. Let's see, we got Glenn coming in from Pennsylvania. We got Rob from Indiana with his blueberry. Oh, I love blueberry coffee. It's weird, but it tastes good. Let's see, we got, who else we got? We got Marianne. Marianne, darling, are you like buried in snow right now over in South Dakota? We got Scott coming in from snowy West Virginia, drinking his Sprite Zero. We got Tom on board. What's going on, Tom? We got Eric from the YouTube channel. We got Angela. Oh, Angela, I'm so glad you're here. Yay, I've got your question ready to go. We got Jenny with lemonade in her cup. And we got, let's see, Scott's got to start his therapy on Tuesday. Good for you, Susan. Oh, hello, Susan. We've got Beth coming. Man, we got all of our wonderful regulars on board. We got Emily coming in from Central PA. Saturday will be 1 year since my amputation, her first ampuversary, longest and shortest year of my life. Very well said. Compadre, good to see you, man. Good to see you. Oh, yeah, we got Pastor David on board, so it's a party. We got Randall coming in from San Diego, Kathy, Comadres here, man. It's really a party. We got Victor coming in from Tennessee. Wow, all these people. Guys, I thank you so much for coming. Ed says, hi, Cosi, big cup you got there. Yes, no, I like my coffee cups huge because I can fit more coffee. Or in this case, tea. It's kind of boring tea this evening. All right, we got Ben Gregory on board. Oh, in West Palm Beach, you're escaping the cold weather then. And Denise and Joan, aloha, Joan. So guys, I will be flip-flopping back and forth between my Instagram and my regular streaming software. So those of you who are listening to me from Instagram, welcome. Join the Cosi Talks Club. All right, guys, I've got a wonderful group here. I'm going to go ahead and officially get started. For those of you who are joining me for the first time, welcome. My name is Cosi Belloso. I'm a physical therapist, amputee specialist in somewhat chilly Florida right now. It is a respectable 40-something degrees here in Tampa. So there, not as bad as some of the snow that some of y'all are getting further up north though. So stay warm. I've been a PT now for a little over 23 years. I got 23 years. That's a long time. And my passion is working with the amputee and limb loss community. So this past week, I've been trying, you guys have been seeing hopefully some fun stuff going on my social media. I've got someone helping me out with social media. So we're trying out all these great videos and all this footage I have sitting on my phone that I can now kind of put out there a little bit more. So I put a video out there and I'm going to show you shortly about what is the #1 skill that you need to have to master walking with your prosthesis. All right, so before we get into those details, I want to hear your guesses right now, guys, in the comment section. What is your educated guess on if I had to pick one skill as a physical therapist? And though some of you have been watching my show for a few years, hopefully you'll get this, right? What is the #1 skill you think you need to have to walk successfully with your prosthetic device? Go. Let's see. In the meantime, Emily says, I'm a left BK and use crutches too, and she gets tired as well. Beth says, my biggest walking issue is fatigue. Yes. Yes. So Scott is guessing balance. Let's see what else we got. Joan is saying core strength. Let's see, anybody from my Instagram channel chiming in. Catherine says stance stability. Jody says balance. Gabby says core strength. Hey there, Pam. Thank you for listening in from the Instagram channel. All right. So guess what, guys? Catherine from Instagram got it right. It's stance. Many of you are saying balance. I'm not discrediting any of these things. Yes, balance, coordination, core strength, ham and quad strength, definitely all play a role. It's not just one small thing, but if you had to pick one thing that is the most important, to me, it's stance phase. Okay, so let's talk a little bit about that, because I know some of you are just like, maybe you haven't seen my channel before, you may not have heard my talk on gait before. So we're going to give you the 101 on gait. And I've got a cool picture here that I kind of want to show y'all. All right, guys, bear with me. I'm going to share this picture to show you what I'm talking about. Here we go. Okay. So hopefully you guys can see, this is a picture of the gait cycle. And any of you who have attended my talks, you know that I have a talk specifically on the gait cycle. If you haven't seen that particular talk, it's on my YouTube channel. It's a really big description on the human gait cycle, okay? But just we're going to keep it real simple for this evening, right? So the two biggest parts of the gait cycle are the stance phase, right? And the swing phase, and you can see it labeled right here, okay? Stance phase is when your foot is in contact with the ground, right? And it's easy to remember. Stance, standing, right? Standing on it. Swing phase is exactly that. It's when your foot is swinging through the air. So when your physical therapist and your prosthetist are talking and describing things about your gait cycle, and we're talking all that, mumbo jumbo, right? We reference the foot as whether it's in stance phase or swing phase. I might say, you know what, when my patient is in stance phase, they've got a little bit of a hip drop going on. So I'm referencing when the foot is in contact with the floor, right? Capiche so far? So far, so good. All right, I'm going to stop sharing. Did that photo go through, guys? Can you guys give me a thumbs up real quick? Did you guys see that picture? Thumbs up. Instagram people, did that come up? Coach Mac, thank you for joining in, man. I have had a great time watching the videos of your athletes. It is just a joy to watch them training. All right, guys, so we are talking. So Catherine, you saw it. Great. Okay, so let's get back to it, guys. Why is it that stance phase is so important in the gait cycle, right? Basically, that's where you're putting your weight. Okay, so this is where, the rubber meets the road, right? This is where if your prosthetist did a good job in building your socket. This is where if your physical therapist did a good job in strengthening those glute muscles, right? So when you're in stance phase, your body weight is being supported by that prosthesis, by that socket. There's a lot of trust that goes into there. So show of hands, show of virtual hands. How many of you guys experienced a lot of hesitation, fear, and anxiety when you first started putting weight into your socket? Or if in the case of osseointegration, my osseointegration viewers, when you started putting weight into your prosthesis, right? It's the deer in the headlights, white knuckles on the parallel bars, right? When that starts to happen, okay? In order for your brain, everybody's like, yeah, me. We're getting lots of responses on that one, right? Okay, so guys, in order, for you to be able to use both legs equally, your sound leg and your prosthetic leg, you got to trust that leg. You got to be able to support the weight into that prosthetic socket, right? You have to have a very sturdy stance phase, right? The big muscle groups that are being activated during stance phase are the glute muscles, right? That's another one of my favorite sayings. It's all about the butt, right? And I think one of you all guessed it in the social media today. One of you guys said it's the butt, right? So the muscle strength in the gluteals and the glutes goes into this, okay? And I believe we have a coach here listening in, and he works with very high-end athletes, including amputee athletes, and he can probably vouch for this as well. In order for his athletes to really be able to take off in a sprint, to be able to do a long jump, to be able to do a high jump, they have to really be able to trust that prosthesis. They have to really be able to go into that stance phase quickly, right? And push off, right? So all of these things are here. All right. Now, here's the kicker, right? Hey, Carolyn. I know Jenny says trusting the leg is so hard at first. I mean, yeah, the best way I can describe it to somebody who is not an amputee is, imagine putting ourselves on 6 feet stilts and having to try to walk around. And I know that's kind of an oversimplification of what it's like to have to learn how to walk with a prosthesis, but I mean, that's scary, right? Hey there, Mark. Yeah, it's a little chilly out. All right, let's see who else we got going on here. All right, guys, y'all just excuse me. I'm switching back and forth between the Instagram screen to make sure I'm not missing any questions and then back to my other screen. So guys, those of you on Instagram, by the way, don't be shy. Put your questions in the comments section and I will definitely be answering them tonight. Okay, so how do we teach this? Right? And that's like the $1,000,000 question, right? So when dinosaurs roamed the earth and I started off as a physical therapist, right? I would start teaching the gait cycle from heel strike. So what do I mean by that? When we talk about the gait cycle, guys, we reference it from heel strike. So from the minute your heel strikes the ground until the heel strikes the ground again. That's considered to be one gait cycle. And I'm going to share my screen again so that you guys can get a good idea about that. Okay, so if you look at this little picture that I've got here, okay, and I'm pointing over here, where this little skeleton's heel strikes the floor, that's called heel strike or initial contact. Some people call it initial contact, right? And you can see the foot goes on the ground, goes flat, heel comes off, toe comes off, and then it swings through the air, and then it hits again at heel strike, and we start all over again, right? So, the way they trained me in PT school was you start kind of training someone from heel strike, right? And you teach them how to hit the floor with the heel first. I've kind of changed my way of doing that over the years, and I've realized that that's not really where I want to start teaching my amputee patients, okay, how to start the gait cycle. I actually bring them to this part right here, right in the middle. It's called mid stance, okay? And it's called mid stance for a reason. It's in the middle of the stance phase, and it's when your body weight is completely over your prosthesis, right? And I have found, and from watching, colleagues over the years and things like that, I have found that to be much more effective to teach my patients how to start walking, beginning with the stance phase, in the mid stance to be more specific, right? Instead of with the heel strike, all right? So guys, I'm going to test the streaming gods right now, and I'm going to try to show you a video, and I shared it on social media. So if you guys go to my reels on Facebook and Instagram, you'll see this video that I did with a patient that I was working with in Guatemala. Because in Guatemala, I did a beautiful trip with the Range of Motion Project in summer of 2022 with my 2 teenage daughters. Go to Guatemala. This Range of Motion Project has a clinic there, and we saw about 24 patients in the span of a week. Okay. And I was myself and one other physical therapist, and we had about 14 prosthetists, right? So between the one physical therapist and myself, we were in charge of 24 patients to teaching them how to walk. So on average, I would get 2, maybe 3 hours with a patient if I was lucky. And I had to teach them in 2 to 3 hours, everything that I would normally try to teach a patient in 2 to 3 months. Okay, so it was a challenge. So what I did with a lot of these patients is I started them right away on that stance phase. I got them really putting that weight into that prosthesis and into that socket. So I'm going to try to show you a video now of what I was doing there. All right, here we go. Hopefully it'll work. Fingers crossed. Aha, okay. Okay, so guys, as you can hopefully see, let me see if I can make this bigger. It's about as big as I can make it. Okay. So as you can see, this lady is standing, she's above the knee, and she's standing with her full weight on the prosthesis. And you can see that with my arms, I'm trying to get her to bring the weight forward onto her prosthetic leg, okay? She's a little hesitant. You can see that she's kind of grabbing on for dear life for the parallel bars, and that's fine. In the beginning, it's going to be scary. That's why we do it in a safe environment. We've got a chair sitting behind her right here, right? And I've got her leg pretty well supported here with her socket, okay? And I'm making sure that her knee is well supported so it won't buckle on her. So what I'm having her do is I'm just having her gently put the weight into this socket. So I'm going to press play. It's only a few seconds long, so hopefully you guys can kind of get a grasp of it. Okay? And just having her rock onto it and back, okay? Rocking forward and then rocking back, okay? And if you guys can see with her sound leg over here, this sound leg is stepping back and forward, but the weight is staying right here over her prosthetic leg, okay? So in order for her to be able to move her sound leg back and forward, let me just rewind it a little bit. Okay, in order for her to be able to do that, she's really got to put the weight into that prosthesis. Okay, so I'll just let that play for a few more seconds so you guys can see that. All right. All right, so here comes the true test. Did that go through? Thumbs up, guys. Did you guys see that video? Yes, no, maybe so. Yes, Jeff, excellent question. Jeff is asking, is this good advice for a below the knee amputee? Yes, absolutely. And again, like I said, the challenge for me when I went to a place like Guatemala, where I'm just like, okay, I've got 24 patients of all shapes and sizes, all sorts of different amputations, all sorts of different prosthetic devices. And I got 3 days because it took about 3 or 4 days to make the prosthetic devices. So I did a little bit of work with them there, but the meat and potatoes of what I did was in the span of 3 to 4 days, right? So yes, every below the knee, every above the knee, I think we had definitely several bilateral patients there. Okay, I started them all doing this and I just had them drilling. And then I taught the prosthetist because there was 14 prosthetists and 2 PTs. So if there was a freehand prosthetist, grab them in, show them how to do the hand placement and do this exercise. Okay. So this is a wonderful exercise that I would say 99% of amputees learning to use a prosthetic device, they can do this. And I also, when I worked in home health, I would typically put my patients find the safest place in their house to practice this. So the most popular place was the kitchen, especially if you have a kitchen island and you can put one hand on the kitchen island and one hand on the opposite countertop, right? And have a chair behind you for safety. Okay. Some people, they had very narrow hallways, so they could put a chair in the hallway and put their hands on the walls and kind of start doing the exercise that way. Some people would use 2 really sturdy, and I do mean really sturdy chairs that they could put on each side and a chair behind them and practice this exercise. And guys, this is an exercise that if you're a beginner amputee, if you're an intermediate, if you're an advanced amputee, okay, this is a good exercise to always have in your exercise bank. I'm not, I have a few runners that I teach how to run. I'm a runner myself, and I love teaching amputees who are candidates how to run. And there have been times, guys, where I've had a very advanced runner come in, but I have to bring them back to the basics. And this is one of those exercises, right? The other one is the weight shifting exercises that you guys have seen me feature on this show a lot. That's also featured in my exercise program, which, hang on, let me just, I got to do shameless plugging here, right? So for those of you who have purchased either my book or the video program or both, right? You're going to go to the balance section, okay? Phase 1 balance. It doesn't matter if it's above the knee or below the knee amputee. Both are going to have this set of exercises in there, okay? And you're going to be doing, hang on, I'm going to find it for you guys real quick. You guys can reference this, weight shifts, okay? So in the above the knee book, it's balance phase 1, page 80, the weight shifting exercises. So you guys have heard me reference these exercises a lot, okay? That's where, again, start off all of my patients with the weight shifting exercises. And again, even including some of my advanced athletes, because sometimes they might be favoring that sound leg a little too much. We got to bring them back to the basics here, okay? Once they're mastering the weight shifting, then we go back and we go into that stance phase. So that's like the diagonal weight shifting, and you're really progressing by putting the weight into the prosthetic side. Make sense, guys? All right. Emily says, I can get my sound leg forward, but my prosthetic leg feels like it's digging in the ground when I try to move it forward. And again, Emily, I know you're working so hard with your team right now to learn to use the prosthesis. So again, that's a very normal sensation to have sometimes. Sometimes it could be that perhaps you might want to check the height of your prosthesis to make sure that your prosthetic side is not too long. You might also want to check how you're bending your knee. Are you bending your knee well when you bring it underneath you, right? Dawn says, I found I didn't have a problem adjusting to my first amputation as about below the knee, but now I've had a second amputation, having some challenges with my necrotic tissue, so taking longer to heal. Looking forward to walking with both my prosthetics for me. I think it's going to be a breeze, but getting the gait down is the key. Absolutely, Dawn. And Dawn, there are occasional unicorns, I call them unicorns like yourself, that you had a very smooth adjustment, especially if you're a below the knee amputee. I always advocate, though, even if you're having a very smooth transition, I advocate getting a physical therapist on your team. We can help with not just the gait side of it. Obviously, the gait is a huge side of it, but also sussing out any potential issues with strength, balance, coordination, range of motion, little things that perhaps may not be evident to you right now, but just later on down the line could cause potential chronic overuse problems. So Dawn, if you haven't already done so, I would highly recommend that you, go see a physical therapist and just have them eyeball you and see how you're doing overall with your strength, your balance, coordination, all that kind of good stuff. Carolyn asks, would this help with compensation issues? Yes, absolutely, Carolyn. Wonderful question. And the answer is 100% yes. Okay. So what does Carolyn mean by compensation issues? Okay. Here's the dirty secret about our bodies. Our bodies and our brain tend to be a little lazy, right? Our brain and our body will always try to take the easy way out, right? So if something is happening, if your knee is hurting, what are you going to do? You're going to put less weight into the knee, and you're going to kind of swing your leg and do anything you can to not put weight into that knee to cause pain. If you have muscle weakness, what is your body going to do? Your body's going to rely upon the other muscle groups that are stronger, right? It's going to take the path of least resistance. It can be a little bit lazy. So what happens with amputation? Same thing, right? Our muscles will get weak with amputation. It happens, right? Lack of use. The muscles are shortened with the actual amputation itself, right? So the body is just going to go say, well, okay, this leg is not doing its job, so I'm going to go favor the other leg. I'm going to favor the muscles on the other side of the body. And you start to have these imbalances happen. Okay. And I see it a lot, especially with folks who did not have a physical therapist who taught them the gait mechanics and who really enforced them to do the proper rehabilitation protocols, right? So folks will get by and they'll start walking around and they might be able to get from point A to point B and go about their lives. But eventually, right, these little compensations will catch up to them. Okay. So when you start and you build a strong foundation, with working on things like the stance phase that I just mentioned right there, working on your proprioception early on, right? That's my buzzword here on this show, working on the muscle strength. Okay. And we're going to get into that in just a minute. I'm going to explain a little bit more in detail why it's so important for a physical therapist to address muscle strength in an amputee. Okay. But yes, addressing all these issues will help prevent and at the very least minimize how many compensations you have in your gait pattern. It's going to make you a smoother walker, more efficient walker, right? It's going to help with energy efficiency while you're walking. Okay. Dawn says, I've been doing physical therapy myself as well as having a coach. Yes, I love hearing that. I'm doing all my weights at home. I'm up to 150 push-ups a day. Dawn, you're a beast. That's wonderful. Staying strong, hoping to be back on track with my ambulance team and my other paramedics to continue helping people. Dawn, I am so glad you came on the show and shared that with us this evening. That is awesome. Yes, right there. Let's see. Beth says, I participated in an intense 6-day gait training program, 4 days, 4 hours a day. Woo! At Spalding. Love me some Spalding. Let me tell you, it was a game changer for me. Yeah. Bonita, I love your name, Bonita. She says, I have fluid in my right above knee. It's really uncomfortable when I put weight. I was born without legs. Okay, so Bonita, this is something that you definitely should check with your prosthetist and check with your doctor to see where is this fluid coming from. And again, I can't, it's hard for me if I can't see you and be able to see what's going on. But when it comes to fluid collection in the residual limb, again, one of the possibilities might be if it's a poor socket fit, right? And that's causing irritation that can sometimes create fluid buildup in edema or with a cyst or with a bursitis, a couple of things, but it's not something that you want to not have checked out. Okay, so definitely I would say, talk with your doctor, talk with your prosthetist, see where is this coming from. And if it is in fact from the socket not fitting properly, then you gotta squeak the wheel with the prosthetist until you get that right fit. Rob says, I spent hours and hours at IU Neuroscience PT on a computer working on stance and weight shifting. Hated it, but it worked wonders. Rob, I usually tell my patients that if they like me, it means I'm not doing my job well enough. Let's see. Will this help with whipping? Yes. So what Pam is referring to in terms of whip, and let me see if I can't demonstrate it here. Okay. So if the person is I know this looks, oh wait, let me see if I can get Bob. Hopefully I can demonstrate whipping with Bob. Guys, this is Bob. He is my snarky and somewhat reluctant mascot for the show. All right. So if somebody is whipping, right, it can either be a medial whip where when they're walking, right, and it'll whip in like this, or a lateral whip where they're walking and like their leg just kind of does a little whip outwards whipping direction, right? So that can happen, and that is considered to be a gait compensation. There's a few different reasons for that, depending on, if you're above the knee and below the knee. It could be due to weakness. It could be due to a prosthesis being a little bit too long. It could be to the fact that you don't know how to bend your knee properly, especially in my above the knee amputees. A few different reasons why it goes wrong, but ultimately it's a gait compensation. Okay, so meaning your body is trying to take the easy way out, maybe because of the weakness or because you haven't learned the proper gait mechanics. Okay, so again, you go back to the basics. And guys, there are some folks who are beautiful walkers, but every once in a while, and they'll tell me, they're like, yeah, I'm getting a little lazy with my walking, and I haven't been doing my strength training like I normally do, and I'm starting to see little things creep into my gait pattern, and you got to just kind of take it back and work on it again. Okay. Susan, yes. Susan saying, Pam, could it be that your leg is not on properly? It happens if the foot is turned out too much. Yes. So Susan, a couple of different things that can cause a whip is, yes, you don't have the prosthesis on properly. Also, if it's a little too long. A couple of things. So if you're not bending the knee properly, that was the other part of it. Bonita says, I had an MRI. Okay, so it'll be interesting to see, Bonita, what they say and then what you can do after that. So the key to something like that, the same way if you have skin breakdown on your residual limb, is finding not only treating the skin breakdown, or in your case, treating the fluid collection, but ultimately finding out what caused it. Okay. So Carolyn says, it's not off subject, Carolyn. Wondering if you ran into an amputee that swells with every shower. If so, how do you fix that? Okay, so reasons you could possibly be swelling in the shower, specifically with your residual limb. Typically, especially if you are wearing your prosthesis all day long, right? When you take your prosthesis off, you might experience what we call rebound edema. Okay, so basically in walking all day with your prosthesis, right, you're creating a fluid pump, right? So when you put the weight into your prosthesis, it encourages the fluid to pump out of your residual limb. Okay, that's actually a pretty good thing. It means your residual limb will start to shrink throughout the course of the day. So when you take off your prosthesis, right, you don't have that pump anymore, and then the fluid just follows gravity and it goes back into your limb. So that could probably be a reason why when you go in the shower, your limb swells up a little bit. Plus, if you like a warm or a hot shower, right, that's going to encourage vasodilation, meaning it's going to encourage your vasculature, your veins to kind of open up a little bit and allow that fluid to go down in a little bit more. Okay. That could be the reason. If you have vascular issues, then that's going to be exacerbated a little bit with the warm shower. In terms of fixing it, again, do your due diligence, make sure there's nothing else going wrong, ask your doctor about that. But if it's just a simple matter of gravity taking effect, then after you take your shower, it could be just as simple as putting your shrinker on, right? Drying everything off properly, putting your shrinker on and elevating your residual limb for just a little bit. Okay. Just to let that edema or that fluid, extra fluid that's going into your limb to resolve just a little bit. Moye, Queen Moye. I'm not sure if I'm even saying that. Hello, and thank you for coming. Pat says, I wholeheartedly agree with getting the support of a physical therapist early on in prosthetic learning process and would be suggesting locating one that is an amputee specialist if available. Thank you very much for that plug, Pat. So guys, I started this show 6 years ago. I've been doing this show now for 6 years. And one of the biggest, motivation for starting this show was to help people understand and learn about the beauty of physical therapy. And yeah, I'm totally biased because that's the field I chose to go into. But it was a huge shock to me when I moved to the Tampa area to see that there really weren't any PTs around who were hanging a shingle and saying that they worked and specialized in amputee care. And how little knowledge there was out there about the benefits of physical therapy and the importance of it. I came from a hospital in Miami where we had a comprehensive amputee program. So yeah, PT was right there next to the surgeon from day one, along with the occupational therapist and psych and mental health services and social worker and vocational rehab, right? So I come here to Tampa, and unfortunately, we really don't have a place other than the VA that has a comprehensive amputee program. So, and when I would go online and on Facebook and I would, listen in on the support groups and I'd hear you all chit-chatting and just seeing that there really not many of you have had access to a physical therapist. So that's kind of been one of my big with this show is to hopefully bring that information. All right. So Rob says he has fluctuations with showers, mainly shower at night, but the adjustable socket has helped if I need to wear the leg after a shower or swimming. So let me see, I've got my box of toys. My trusty Click Medical socket. So guys, Click Medical, back on the show this year. So we're going to be talking a lot about adjustable sockets. But Carolyn, this for me has been a wonderful, wonderful option for a lot of my patients and viewers, especially those that do experience a lot of volume fluctuation throughout their day. And in the shower and in the mornings, in the shower, that's another great one. So basically, this is a demo socket. So this has a lot of action going on. But an adjustable socket is exactly that. It gives you the ability to adjust the socket. Okay. So I just pulled that out more so you guys could see it. This is one example. You can do a panel that way. And they have a new click wheel. This is the boa dial version. Okay. And then you also have a gap and then a hinge that you can use model. Pam, the $1 million question, she is asking, how do you find a PT with amputee experience? Yeah. So bad news is there's not a whole lot of us around. The good news is when you find one who's an amputee specialist, they're usually big nerds like I am, and they really love what they do, and they will treat you from head to toe. So all joking aside, Pam, first just go to Google and just say amputee physical therapy near me. And in many cases, you're going to have to look outside of your zip code. I'm not seeing as many patients right now in my clinic right now, but the majority of my patients would come to me from outside of Tampa. The majority of patients, when they either heard through me through the show or through someone else, and they would come to me from different parts of Florida, from outside of Florida. And it doesn't have to be me, guys. I'm not saying it has to be me. There are PTs around. Lately, I just try to tell people, send me an email and I will try to find you someone close to you who hopefully is a amputee specialist. Another thing I've also been recommending is, if you know of a physical therapist, it doesn't have to be an amputee specialist. A physical therapist is trained on how to assess, diagnose, and treat pathology of the gait cycle. Okay, that's the bread and butter of my profession, guys. It is drilled into us from day one. We are the experts, more than the prosthetist, on assessing and treating the gait cycle. Okay, so if you don't have access to a physical therapist who is hanging a shingle and saying they're an amputee specialist, okay, but you have a PT who wants to help you, the best thing you can do is introduce that physical therapist to your prosthetist and encourage that communication. Okay. The part that the physical therapist might be missing is knowledge of prosthetic componentry. Okay. But everything that they need to know to treat you from a gait training standpoint, they've already got it. They've got it in their education. You might just have to be the catalyst, right? To introducing them to that prosthetist and starting that relationship right there. Okay. When I started out as a physical therapist and I started learning about amputee care, I actually had very, very little education in school. Don't agree with it. Don't know why, but that's the way it was. The bulk of my knowledge came not only from working with a senior physical therapist who was beyond an expert on amputee care, but also working with an amazing prosthetist who just every patient that would come see me, I'd have him by my side saying, all right, Steve, teach me about this particular prosthesis. Teach me about the swing and stance knee. Teach me what you can about this leg. And I would go learning that way. Okay. Neurospecialists. This is something else. Physical therapists who specialize in working with people with traumatic brain injury and strokes, right? They're really great with gait training, right? I know that a lot of the treatment strategies that I use with my amputee patients, I learned from my neuro rotations. So working with stroke patients, working with TBI. Why? Because when you have a stroke or traumatic brain injury, your brain sometimes not only loses control of your leg or your arm, your brain doesn't recognize the leg or the arm. Okay, so similar to when you're using a prosthesis, right? Your brain at first is not recognizing that prosthesis as a part of your body. Okay, so a lot of the treatment strategies, even that stance exercise that I just showed you guys at the beginning of today's show, right? I use that a lot when I was working with stroke patients. All right. Susan asks, if we know of good PTs who work with amputees, should we let you know? Are you compiling a list? Yes, please. Definitely. No, guys, if you guys have any, I don't have a formalized list yet, but I do have my little contacts here and there. And honestly, whenever I hear about a physical therapist who works with amputees, I try to reach out to them personally and say, hey, how are you, fellow colleague? Let's keep in touch because it's nice to have that networking on a professional level. And then obviously to make those referrals to those of you who are looking for one. So yes, by all means, and here is my email address. Okay. And this address, guys, I answer it myself. Nobody else answers it. If you have any questions, if you want to send me the name of your physical therapist who happens to be an amputee specialist, please send me their name, the city, and the name of their clinic. That would be wonderful. And I am going to start compiling an official list. So thank you, Susan. Emily asks, does the Amputee Coalition have a list of PTs who specialize in amputees? And guys, I love me some Amputee Coalition. I really do. They have a directory for prosthetists, but I haven't seen a directory yet for physical therapists. So maybe we can just kind of politely make that recommendation in their suggestion box because I think that's way overdue. Yes. So if anybody from the Amputee Coalition is listening tonight, can we please do a directory for PTs who specialize in amputee care? Yay? Yes. Okay. I know, right, Sean? All right. Who else we got, guys? All right. You guys are asking some really great questions. Emily says, I drive an hour to therapy twice a week because they specialize in amputees. And again, guys, you can think outside the box. With some of my patients, I don't accept insurance. So for the record, I don't accept insurance at my clinic, which it can be a little bit more of an investment on my patient side, but at the same time, it gives us a lot more flexibility. So for example, for my patients who are coming in from out of town, some of them, they'll come to see me for 2, maybe 3 days in a row. We do an intensive boot camp, and then I can send them home with homework and things to work on, right? Other patients who perhaps are not able to see me, they can only perhaps come once a week or once a month. And again, we try to work around what it is that they can do. Okay. So don't give up. Keep looking for that physical therapist the same way that you look for that perfect not perfect, the best prosthetist for you who can get you that good socket comfort fit. Keep looking around until you find that physical therapist as well. All right, let's start addressing some of these questions. We've got Angela. Angela says, days prior to Christmas, I accidentally fell on the end of my residual limb. Thankful that I did have my liner on. I had stitches that healed really well, and I've been keeping it elevated, massaging my residual limb upwards, putting ice pack on and drinking water. And I also continue with warm cloth and Epsom salt bath. How much time does it take for the swelling to go down to what it was prior? And I've been a right BK for almost 7 years, always been careful. And this prosthetic is the type that the suction liner is over the top of the socket. Guys, when it comes to like accidents like that, first of all, I am so glad that you didn't fracture anything. And the worst case was it was just a really bad bonk. But yeah, the swelling can kind of stay in those soft tissues for a little while. Things that I would just kind of think of just off the top of my head, if you start to see that overall there's no improvement in the swelling, it might be time to go talk to your doctor. But what you want to think about is, okay, is this swelling better than it was a week ago? You may not notice a day-to-day change, especially as you move further out, but is it better than it was a week ago? And you're doing a lot of the things that I would have recommended that you do, keeping it elevated, using gentle massage, ice pack, water intake is a huge thing. Okay. But if you think about it, Angela, because it's a residual limb, because you don't have the rest of the leg there, you don't have the rest of the vasculature, the veins and the arteries, you don't have the rest of the lower leg muscles. And all of those things, like I mentioned earlier, it acts as a pump, right? So as we're walking, right, our muscles, especially our calf muscles, are helping pump fluid up and out of our limb. So when you don't have that, and then on top of that, you have some swelling in there, perhaps from an injury, it might take a little bit of extra time to resolve. But again, Angela, if that's something that you're worried about, just keep checking tabs in with your doctor because they can actually, lay eyes on what's going on to make sure that there's nothing else there. Okay. Did I miss a question? Beth says, do not be afraid to fire a PT who does not align with your goals. My girl is not pulling any punches right there. So guys, you hear me, those of you who've heard me on the show, you've heard me talk about, holding your clinicians accountable, whether it's your surgeon, your physical therapist, or your prosthetist. And I'm an equal opportunity, throw them under the bus person, right? So, I've stated in the past where, if you're having trouble communicating with your prosthetist, you feel like they're not listening to your needs, if you feel like your socket is just not comfortable and they're not willing to work with you, right? Time to go look for another clinician. Same thing with the physical therapist. If that physical therapist is just putting a hot pack on you, putting you on a bicycle and walking you around the clinic once with a walker and calling that physical therapy, time to look for a new physical therapist. Yeah. Yeah. And guys, for the, I joke around, but I was kind of thinking about that today, and I was just like, I had some really intense training, in my early years as a physical therapist, and I'm so grateful. I had some mentors who, man, they were tough nuts to crack. And they held me to a very, very high standard of clinical care. That's probably why I'm a little bit about, maintaining a clinical standard and for the rest of my colleagues as well. But being held to a higher standard of clinical care, it means that you're always questioning yourself with your patients, always making sure, am I doing the best for my patient? Am I keeping up with their care? Is the treatment I'm giving them now effective? Is it working? Is it not working? How can I improve? Am I slacking off? Do I need to, things that are always going through, a clinician's head. And as a patient, you should also be advocating for yourself and having that line of communication open with your clinician to make sure that you guys are staying on track with what your goals are. Okay. Robin, hey, there's my girl. What's up, Robin? All right, let's see. Mhm. All right, Instagram, you guys are a little bit quiet, and that's okay if you're a little bit quiet. It's all right. But if you do have any questions, Instagram, feel free to put it in your comments section right there. All right, next question. Mhm. Jeff says, I watched your live video tonight and it was very informational. A little bit about me. I lost my toes on my right foot due to an infection, type 2 diabetic. A year later, I lost my left below the knee due to poor circulation. So on the left side of BK, on the right side, missing some toes. In my left leg, I had polio when I was a child and many surgeries to try to make me walk. It worked to some degree, and I played sports through high school and have had to work construction my whole life. I have very weak or missing muscles above the knee, so it is a struggle to make a prosthetic work right. Everything feels like a huge weight hanging under my knee. Have you ever had encounters with someone with my problems? I'm keeping my head up and moving forward. It's just a struggle. So yes, obviously, we don't see polio as much, but I do on occasion see someone who had polio as a child, and the weakness in that particular limb. It's a lifelong weakness. So and there have been many of you on the show who have shared that you either had a congenital malformation that eventually led to your amputation, or perhaps you had a severe accident as a child that over the years of limb salvage surgery eventually ended in amputation. Okay. So when you have cases like this, when you're looking at decades, right? Decades of surgeries or decades of uh, weakness or malformation of the limb somehow that will cause weakness in other parts of the body and that will cause other compensations and other issues in the body. The important thing from a physical therapist standpoint is really truly looking at the person from head to toe. You're supposed to do that anyways as a clinician, but especially with someone who's had a lifelong, journey with this. So for someone like this individual here who has a history of polio, I'm going to be looking up to see what his spine is doing. I'm going to look to see what the other leg looks like. I'm going to look to see what his alignment is looking like. Am I going to be able to change a lot of things? Perhaps not, because again, a lot of times the body might change the alignment either with a scoliosis or pelvic rotation or something like that going on. And we may not necessarily be able to correct it at a later stage in life, but we can certainly help manage it with certain strengthening, with certain positioning and things like that. Okay. So again, these cases can be a little more complicated because you're not dealing just with the amputated leg, you're dealing with the whole body that has undergone a lot of trauma over the years. But I've seen some very successful cases of folks who just continue to work. You have to work a little bit harder. I need a drink here. Woo, tea. Okay, so in cases like someone who has had a history of polio or a history of an accident, again, looking to see what the whole body is doing. And this is where, again, the team relationship between the prosthetist, the orthotist, perhaps as well, and the physical therapist is so key to helping, manage the amputation, manage the amputated side. If there's any availability to strengthen some of those muscles or at least maintain the strength that it has. And then also helping strengthen the stronger leg to make sure that you don't run into any chronic injuries there. Okay, that's another important thing. Hola, Lisbeth. Feliz Año Nuevo. Good to see you. All right, we got Tracy on board as well. Hey there, how are you, Tracy? Okay, so Emily says, so here's Jeff, if you're listening right now, this is a wonderful example. Emily has been wonderful about sharing her experiences. She says, I have spina bifida and my prosthesis feels heavy and hard to walk. My muscles aren't as strong as a person who was fully able to before amputation to begin with. So again, if it's the prosthesis feeling heavy, obviously there could be issues with strengthening, specifically with the gluteal muscles and the core muscles as well. And the efficiency with gait, that's the other side of it. Again, this is where doing exercises that work on stance with getting you to put trust into the prosthesis to hopefully use it a little bit more can help with this. Also just, checking your suspension from a prosthetic standpoint, working with your prosthetist to see what is the best way that you can suspend that prosthesis. Because if you have good suspension, the prosthesis is not going to feel quite as heavy. Okay. So finding a prosthetist who's really good at different suspension techniques, looking at the componentry that you have, right? So you want to find a prosthetic foot that is going to meet your needs, right? To meet your needs for mobility. But look, check out the weight, right? Check out the weight of each foot. In cases like yours, if you have a history of polio, if you have a history of spina bifida, ounces in the foot could potentially make a difference in how heavy that it feels. So you just, you try to address little things here and there to bring it all together into the whole picture. So my pleasure, guys. Okay. Oh, Beth, that's a great question. Beth is asking, is there any way to combat permanent nerve damage in upper leg and residual limb? If there have been nerve conduction studies done, and that there's not impulse activity going through those nerves, and usually after the 2-year mark, the literature will tell you that what you see is what you get with the nerve. What we were taught, as physical therapists, is to kind of preserve. So if there is any, if the nerve is active and able to activate the muscle, to try to keep that strength without stressing that nerve and that muscle out. And then especially if it's sensory nerves where you've lost sensation, then it's making sure that that skin is protected and that you are constantly examining that skin, because if you can't feel the skin, you can't feel if there's a lesion on that skin. When there's a permanent paralysis, whether it's an entire limb, as with spinal cord injury or stroke, or if it's a partial paralysis with nerve damage, more peripheral nerve damage, it's again strengthening what you have, maintaining what you have, and then if there's not enough strength there, then looking at the muscle groups around it to really strengthen those muscle groups so that they are capable of taking that load on. Okay. Ashley asks, my ortho and PT think I have a small labral tear. How can I prevent further damage besides continuing my home exercises? I had 2 significant falls this past summer and always tend to fall towards the right side. I'm a right BK, and it seems like when I fall, it's towards that side and it affects my shoulder. So Ashley, can you be more specific? Is it a labral tear of your shoulder labrum or your hip labrum? And then I can kind of sort of try to help you out with that one. Let's see. Hang on, guys. Popping over to Instagram, making sure we're good. So on Instagram, Humphrey says, what is the cause of poor knee flexion in a trans tibia patient while ambulating? Okay, so if you mean if the knee is in a flexion contracture, meaning it's stuck in flexion, then that's usually a tightness of the hamstrings. It's a very common thing that will happen with our below the knee amputees. So it's something that needs to be worked on. If it's an inability to flex the knee during walking, so for example, if the person has more of like a stiff leg gait and they're not bending the knee well, sometimes that's due to just gait inefficiency. They're just afraid, right, to bend that knee because it's easier to swing the knee out. Going back to the compensations that I was talking about earlier in the show tonight, it could also be, again, I'd have to kind of like see the person walking to really be able to tell you what's going on. It could also be that there's weakness of the quads and the hamstrings. So if the person has weakness in the quads and the hamstrings and probably the glutes, they're going to want to probably keep their knee straight as they're walking because it's a little bit safer. So they might lock their knee out and not want to bend it as much. So just a few options there, a few reasons as to why that could be. All right. So shoulder. So going back to Ashley, in terms of a labral tear with the shoulder, a lot of it, and again, Ashley, this is where you need to talk to your surgeon. Talk to your surgeon and see if it's a surgical repair that might be needed. Okay, so let's just talk a little bit about basic anatomy. Come here, Bob. All right. So we've got all sorts of cartilage and protective gushy stuff in our body. And I know that's a real technical term right there, gushy stuff. Way to go, Cosi. Give me a break. It's 9:30. It's late. All right. So in our Actually, Bob, no offense, dude, but you got a lousy shoulder joint. It's not very well made. I'm trying to see if this Bob has a better. Okay, kind of sort of you can see over here. All right, so in Big Bob, we got Big Bob, we got Little Bob, right? In Big Bob over here, you can see where his shoulder joint is right there. And on the inside part here is going to be a little cartilage, and it's just coating the inside of where his shoulder is. So on the inside part here is called the labrum, right? And it's just a cartilage that coats the inside. It helps provide more surface area, right, for the ball and socket joint to move. So you have that as well in your hip joint, right, in the labrum right here. Sometimes that will tear, and that's a pretty significant injury, right? It can cause a lot of pain, a lot of discomfort. Ashley, it's been a while, but the last time I checked the literature, it can cause just erosion over the course of time and just cause a point of arthritis if it is not repaired. But again, it depends on the size. If it's something that's super duper small, okay, in some cases it can kind of heal on its own, but there will be a little bit of scarring. So Ashley, this is something I would just have that conversation with your surgeon and ask them, what do they think? Is this something that will require surgery down the line? Is this a particular labral tear that's small enough that it could heal on its own? Definitely you got to kind of baby that shoulder a little bit more. You're not going to be doing massive push-ups and pull-ups with that kind of a shoulder if you've got a suspected labral tear in there. And again, this is where your physical therapist, and I know you've got a tight relationship with your PT, to teach you exercises that will help maintain the motion, right? The range of motion in your shoulder and strengthening the muscles around it. But in terms of heavy duty activity, you're going to have to lay off on that. And I'm pretty sure they probably already told you about that by now. Let's see. Jerry asks, have you heard of a tibia bone being too soft to use a prosthetic? So if you're referring to osteoporosis or osteopenia, that is something that develops in amputees, right? So when we are walking and when we're using our right, the pressure and the force of our limbs hitting the floor stimulates your bone marrow to produce more bone cells, right? And they replenish themselves. So when you're using a socket, you're actually not putting weight into the bone. It's a popular misconception. The weight of your body is being distributed among the soft tissue, so among the muscle, right, of the residual limb. Okay, so what happens is, since you're not putting weight into the bone in your residual limb, that bone is going to get weak. Okay, and especially for our ladies, right, as we get older, we're already losing bone mass and bone density. So if you're a female amputee, that's going to be a little course of your annual check primary doctor to ask about getting the occasional bone density test to see how your bone density is doing. One of the reasons I would see someone not being able to use a prosthesis is if they have a fracture, for example, from the osteopenia or osteoporosis, if they have a pathological fracture because of that. And that's a pretty extreme case. So that's usually when I've heard of somebody not being able to use their prosthesis. And again, Jerry Ann, this is something that if you do have a history of osteopenia or osteoporosis, it's really important that your doctor is doing regular checkups to see how that is progressing and whether you might need medical management for that. A good strengthening program. A lot of the research has shown that weight bearing and a weight training program can actually help improve bone density in women who experience osteopenia. So that's something to look into. So Victor says, I've been a right below the knee since September of last year, so approximately for 4 to 5 months. Only been able to use my prosthesis about 2 weeks, then had to stop due to an open sore on the scar on my left leg, and it's now starting to give out. Anything I can do to strengthen it? Okay, so yes, Victor. And again, the first few months of learning to use a prosthesis can definitely be the most frustrating. And sometimes it's a 2 steps forward, 1 step back scenario. Definitely, just kind of backtrack a little bit when it comes to skincare. This is something where, again, Your physical therapist should be talking to you a lot about skincare and skin management and protecting that skin and using a wearing schedule so that your skin can get used to the pressures of a prosthesis, right? Also determining if you had an open sore, did it come from wearing the prosthesis for too long? Did it come from a pressure point in the prosthesis itself, right? Where did that pressure sore coming from to hopefully prevent it from happening again once you're able to start using your prosthesis? In the meantime, yes, there are strengthening exercises that you can be doing for your sound leg and also for your residual limb while you're waiting for that to heal. Happens all the time for my patients where I'll send them home with a home exercise program to maintain their strength as we're waiting for their skin to heal. Again, physical therapist, the strengthening program that I have developed for physical therapy for amputees. Okay. It's right there. It's 150 videos, exercise videos, as well as 2 books that I've published to go with those videos. And in that video and in the books, all the exercises that are done for the residual limb can also be done for the sound limb to help keep that strength up. Van Gregory says, shamelessly tooting my horn and an update on my running blades. I've joined a running club and completed 4 5Ks. Holy cow, Van Gregory. Walked 2 to get familiar with the course and walked 2. 2 miles jogging, 1 mile walking on each. Thank you for the tip support. Much appreciated. Congratulations, Van Gregory. That is wonderful. And if you have the ability, I would love to see an updated video of your running. Hopefully not getting into any more fights with the sidewalk. But congratulations, Van Gregory. That's wonderful. Wonderful. So Ashley Zay is a small tear, not surgical at this point. My fear is that if I fall again, it will become a surgical issue. Yeah. I mean, Ashley, and this is, I had an orthopedic physician that described a labral tear very accurately. And I remember a friend of mine, she had a hip, she was an incredible runner, but she did develop a labral tear in her hip. And she was going to go in for surgery, and in her case, her labral tear was significant enough to require surgery. And she was asking the surgeon, can I go running? Even, I'm not having any pain right now. Can I go running before my surgery? The doctor said this: right now, your labral tear looks like this. If you run or if you do crazy jumping things or fall down, that will become your labral tear. So Ashley, I'm not saying that to scare you, but I am saying, yeah, you got to be careful, right? If your propensity to fall is due to balance, then work on your balance with your PT. If your propensity to fall is just from being distracted, take care of yourself, girl, because we don't want that labral tear to get any worse. Okay, in all seriousness. All right, my pleasure, Carolyn. So Victor says the sore came from not being closed right. Okay, and especially if it's on that scar line, sometimes it can be a little tricky because around that scar area, that scar tissue is not going to be as juicy as the rest of the skin, and it may not have as much circulation there. And then when the time comes, and you're going to want to be careful of is one line heals, that's very sensitive around that area, even though closed. I would recommend to stay in your physical to put you on a very careful wearing schedule so that your skin can get used to the load of wearing a prosthesis again, and it won't open again. Let's see. Jerry Ann says, I do have both osteoporosis and osteopenia. I'm a bilateral chair again from Revin healing still. And again, so Jerry Ann, and again, I gotta dig up these research studies, but these are research studies, guys, that were done back when I was a student. So we're talking 25 years ago. We had studies showing that a prescribed strengthening program by a physical therapist. So this is something that you would need to go to a physical therapist to have this prescribed properly. A lightweight training program, and we're not even talking about like 20-pound weights. We're talking like 1 to 3 pound weights. Made a significant difference in bone density and following that kind of a program. So Jerry Ann, I'm not sure if you have access, but if you can find yourself a physical therapist, and in this case, again, Doesn't have to be a PT specialist, right? This is something that all PTs, licensed physical therapists, are trained to do, to work with people who have osteopenia, osteoporosis, and help keep them strong and hopefully improve some of that bone density. So it'd be worth checking out. So Jenny will say, just had the labrum. Just had the labrum in my hip on my amputated side repaired in November. Full rehab, but improving every day. Jenny has been killing it. If you guys don't follow her yet on Instagram, you need to. She's under. I'm gonna brag a little bit about you, Jenny. She's under the handle Slim Jenny. So if you don't have the chance, she is so much fun to watch. So much fun. Okay. So wound is from the amputation surgery. Yeah. So if he's having a malclosure, it's not closing all the way. Again, all the more reason that when he does start to use the prosthesis again, that he's especially paying attention to that scar line and really watching it like a hawk to make sure that there's no undue redness there in that area. Ashley says, my falls were because I woke up in the middle of the night. Oh no, and forgot to tighten my socket, and I have an adjustable socket. Oh, Ashley. And I've had that happen. I would go to my home health patients. I did home health for several years. And sometimes my patients kind of sheepishly, and they'd be like, I got up in the middle of the night and I forgot I don't have a leg, and I tried walking and I fell. And I go, you know what? It happens all the time. I hear about that all the time. So when I would have patients like that, little perhaps disoriented or a little forgetful at night, who wouldn't be, to put a walker right at the bedside so that when they sit up in bed, that walker right there in front of them, and hopefully it'll either jog your memory, Ashley, to tighten up that socket, or at least encourage you to use the walker and prevent those falls from happening. All right. Okay. We have, okay, here's this one last question that I wanted to get. This question was sent to me through my texting service, guys. Here, I'm going to put this up there. Those of you who would like to receive text alerts, on Wednesday nights, I send out links. I send out a text to my texting service, and with it, the links to where I'm going live. Some people find it easier to find me that way. And then in turn, you can also text me your questions directly. All you have to do is text Cosi Talks to that number right there, all caps, one word. So speaking of which, this last question came in from the texting messages, and this person asked, my shrinker likes to slide down. Is that due to the shrinker being too big or the swelling in my leg pushing it down? My PT said it was due to the swelling. I thought the shrinker was getting too loose or losing its elasticity. So if your physical therapist has already said it's because your leg is getting too swollen, okay, then the next step would be to ask them, hey, can I get fit for a different shrinker? And here, let me just show you. Unfortunately, I do not have a shrinker with me, so we're just going to kind of pretend this liner is a shrinker. So if your leg is swollen, usually what I would see happen is like the shrinker would kind of just like slide down, right? And you're left with all this empty space at the bottom. So sometimes what the prosthetist might do is might go a size up in the shrinker so that the bottom part fits snugly, and then they might just put a seam in to fit the rest of the shrinker and kind of customize it a little bit. So whenever I would have that problem with one of my patients, I would just ask the prosthetist, hey, can we just go up a size in the shrinker, right? So that the bottom part is fully contact there, because that's where you need the best compression, is at the bottom. And then, just adjust the top part to make it fit comfortably there. So Susan asks, how come some PTs have shrinkers and some do not? I never did. A lot of times it has to do with the surgeons and their protocols. Every surgeon is a little bit different. Some surgeons, they want their patients to have shrinkers or some sort of compression device, whether it's a tubey sock or an actual shrinker, right after surgery. Man, my throat is tickling. Okay. Other surgeons say, no, thank you. Don't put anything on that leg. I want to protect that surgical site and the stitches, et cetera, et cetera, et cetera. So that could be the reason why. I love the use of a shrinker in compression. If the surgeon is allowing it, then I say, yay, go for it, because I think it helps with pushing that fluid out of the limb. And that aids with the healing process, and it aids with just feeling pain relief as well, because you're pushing all that fluid out. Some people continue to use their shrinker. No, I highly recommend, especially once the stitches are out and that wound has healed, definitely the use of the shrinker helps keep the fluid out of your limb. So a couple of things is, do not wear the shrinker with your prosthesis, right? You're either wearing your prosthesis or you're wearing the shrinker, not both at the same time. I always like to make that point, okay? And then also for nighttime wearing. A lot of folks, when they wake up first thing in the morning, they're going to have trouble getting into their prosthesis because their limb may have swollen a little bit during the night, excuse me. So putting on a shrinker can help keep that volume down during the night and make it a little bit easier to use in the morning. But not everybody is like that. So for example, Emily says, I ace wrapped until the stitches were removed, and then I got a shrinker. Yep, we still use the old-fashioned compression ace wrap. Beth says, my residual limb is very unhappy if I don't have compression, and each of us has different needs in that respect. Yeah, and a lot of my patients, usually well after their first or second year after amputation, they continue to use the shrinker because they just feel comfortable. It just feels more comfortable at night to have that soft tissue kind of compressed and compartmentalized there. All right, guys. So that is all the time that we have for this evening. This has been awesome. I'm going to go ahead and shut down the show for Instagram, that's how I'm supposed to do it. And then just to let you guys know that next week, what's next week? Next week is the 24th. All right. So we're having another general Q&A. So guys, send me your questions. Here is my email address. Whew. All right. And guys, keep an eye on the social media. I'm doing a lot of fun things there. Anything you can do to share the content that I'm producing, like, comment, give me your overly critical responses there. Everything. I love it. Love seeing it. Love hearing it. So guys, we'll be hearing from you hopefully next week. Same bat time, same bat channel. As always, thank you for letting me be a part of your lives this evening. And have a great night, guys. God bless.